Hi, everyone. I'm Dr. Samantha, the maternity mentor, and welcome back to another one of our live Q&A sessions that we have here every Monday at 9 p.m. Eastern Standard Time. We love having these sessions. This is a chance for us to interact with you live, to answer any questions that you might have, as well as to answer questions that some of our viewers, including yourself, may have put onto our onto our videos every week. Remember, we're also on Facebook, Instagram, and Twitter for additional content, and we will link those into the description. Please make sure you like and subscribe to the channel. It really helps us out. And hit that notification bell, because that notification bell lets you know when we have new videos coming out. And we have some really exciting content. And for those of you who haven't checked it out, you should really check out last week's video about birth plans. That's been out. It's a very great video about what to put into your birth plan. And at the end of this video, I'll let you guys know what you can expect tomorrow. So I'm going to go ahead and get started. And we actually have a question that's already in the chat, which is awesome. So welcome, Jasmine. Thank you for joining us. Jasmine says, hello, I am 30 weeks pregnant and I have a 21-month-old. Sometimes she's a little rough when playing and she will accidentally graze or hit my stomach, or sometimes she will try to jump on me. Is this a risk to the baby? So this is actually a great question, Jasmine. And I love that you've put this on there. And actually, it kind of inspires me maybe to do a video on how to be pregnant with a toddler. So toddlers are a little rough and they don't always, respect boundaries. And so this could be a very big concern. So I'm going to tell you there's kind of two things to consider. The first is how hard her hits are. And second, do you have a high-risk pregnancy? So let's start with the high-risk pregnancy part. If you're a mom who's possibly having an incompetent cervix, or there's a risk that your water is going to rupture early, you're having any kind of complications, you do need to be a little bit more careful. Going to question 2 or point 1, is she rough? It does depend on how rough she is. Now, I'm going to tell you the average 21-month-old toddler is not going to be able to graze or hit your stomach hard enough to cause any issues. So the biggest thing I see there is her trying to jump on you. Now, if you're laying flat on your back and she's trying to bounce on you, kind of like she'd bounce on a beach ball, that's probably not good for you. Do I think it's putting a risk to the baby? No, I don't think it's putting a risk to the baby, but it is putting some abdominal pressure on you. And if you do have any kind of issues with your cervix or any kind of risk for a premature rupture of membranes, that could increase the risk, that pressure, that intra-abdominal pressure. Now, if you're sitting and she kind of just jumps into your lap, it's probably going to be just fine. She's not really going to be able to create such an impact that it should be an issue for you. That being said, Jasmine, I would absolutely start working with her now on calming down. She is 21 months old. She can learn to be a little bit softer. Use terms like softer, less rough, gentle. I would also encourage you to not necessarily say be careful of the baby, but maybe just be careful of mommy. Okay. You don't want her to associate any corrective measures at this point with the baby. If she views these corrective measures as negative, right? Even though you're speaking to her and you're trying to tell her to stop and stuff like that, if she views it as negative and you keep using the word baby, when the baby comes, she may have a negative association. So I encourage you to focus on you saying, be careful of mommy, that hurts mommy, be gentle with mommy. And then once she starts to learn those behaviors with you, where she will really ultimately, hopefully have a positive caring aspect to you, her mom, when you're using those same terms with the baby, be careful with the baby, be gentle. Hopefully that'll translate as like a positive feeling. You definitely want to start working with her. A lot of people assume, oh, it's 21 months old, 18 months old. They don't understand. I think this is a really big disservice that parents do for their children. I'm not expecting you to expect your 21-month-old to be making their bed and cleaning up every toy and talking to you in complete sentences. Of course, that's absurd. But talking to her in real, honest, clear language teaches her how to understand those directions, those clear directions. Reinforcing what you need her to do is a great skill for her to have. She'll learn earlier how to handle herself. If she's like crazy and all over the place and the baby comes and she hurts the baby, she's likely going to get in trouble, which is fine. I mean, it's understandable if she hits a newborn, right? But if she wasn't even given the opportunity to learn how to correctly behave, then this is kind of like going to catch her off guard. So you actually have a lot of time to kind of work on this behavior. So I totally encourage you to do that. Okay. For anybody who's joining us, please remember we're here to answer your questions live like Jasmine. So please feel free to put your questions into the chat. I'm going to go ahead and get started with some of our questions from the videos. But again, feel free to put stuff in the chat. I got a question on our antibiotics video. Is it safe to take co-amoxiclav 625 milligrams Augmentin brand for 15 weeks pregnant due to an ear infection / discharge? Okay. So this is a great question. And I love the antibiotic questions for a couple reasons. So the antibiotic questions, first of all, the most common medication a woman is going to be prescribed while she's pregnant is an antibiotic, okay? You're immunocompromised when you're pregnant, which means you're going to be at higher risk for all sorts of infections. And as a result, we need to treat them because infection, if left untreated, can lead to preterm labor, miscarriage, and stillbirth. So we want to make sure that we absolutely get those taken care of. So what happens is we give antibiotics for diagnosed infections, which include urinary tract infections and some infections of the vagina and the uterus, okay? When we give those, we have to be careful to make sure we give something that's safe for the baby. Most antibiotics are safe, but it's good that you're checking it out. So this medication, Augmentin, is safe to use during pregnancy. And so we use it very often. One of the things you need to know, though, is that antibiotics, they treat bacterial infections, right? So what happens is when you have that bacterial infection, you start taking an antibiotic, very quickly, you start to feel better. In fact, like within 24 hours, you can feel like you're completely cured. And please understand you are not completely cured, okay? What happens is the antibiotic kills off like tons of the bacteria right away, like 80% gone, which is why you feel so much better right away. But there's still like 20% in the back. Those are the strong guys. Those are the guys that are smart enough to sit back and see what happens. Now, here's what does happen. That 20% that's left over, it's figured out what you're going to use to kill them. And so if you don't keep taking the antibiotic and you stop, it gives them a chance to build a wall, basically to protect themselves from that particular antibiotic. So now what happens is a couple of days later, they've built their wall, they have a protective defense, and they've started to multiply again. So you're getting sick again. But now when we go to give that same antibiotic, it's not going to work because they've built a defense. This is why it's so important to continue to take all your antibiotics as prescribed, because if you do that, they don't have a chance to build a defense against that medication. Now, this person in particular is mentioning an ear infection, which I think was also a great part of this question. Ear infections with discharge don't always have to be treated with a pill, with an oral antibiotic. So when you have discharge, this means that you've actually ruptured your eardrum, okay? Prior to that, what happens is the infection builds up behind the eardrum, which is like this thin membrane, and that pus just fills and fills and fills and fills and fills. And if it's left untreated, eventually it pops. Now, when it pops, that pus starts coming out of your ear. That's the drainage that you see. Well, once that happens, you don't actually necessarily need an oral antibiotic or a pill. You may be able to get an eardrop, okay? And the eardrop may be enough to take care of that infection. So a lot of people don't realize this. And so they're given a pill and they assume that's all they can take. I would actually encourage you, if you're watching, to see if you can take an eardrop, because an oral antibiotic is going to get into your bloodstream, which means it has a chance to go across the placenta and into the baby's circulation. An eardrop can also get into your bloodstream, but it's usually going to get in at a far lower dose if it gets in at all, which means there's much less risk that any of that will go to the baby. Now, I did use the word risk there. So Augmentin is safe for use during pregnancy, but there's always risks to everything. So that's why we always want to make sure we use the safest medication that we can for the least amount of time that is the most effective. If we're going to use a medication, we want to make sure it's effective. And so that's why in this case, I would see if you could possibly take an eardrop for that. So that was a great question. The next thing that I'm going to talk about is C-sections. So I got a question that said, can you choose not to get Pitocin? Okay, this came in on the C-section video. So I believe what this viewer was referring to was Pitocin after delivery. Okay, so let's talk about this. Pitocin is a medication that a lot of people know about because it's used during labor to help give you contractions, okay? And so a lot of people don't like it because it can make contraction patterns like faster and stronger, which makes people need epidurals. It can also potentially cause the baby to have some stress, and then you end up needing a C-section. So a lot of people are opposed to Pitocin during labor. But especially when you're having a scheduled C-section, you don't really get Pitocin ahead of time. And some labors don't use Pitocin, believe it or not, they just happen. But we use Pitocin afterwards almost universally. So why do we use it? We use Pitocin because that same contraction that is happening happens after birth to help contract your uterus back down to prevent bleeding. So what happens is you have the uterus, right? And you have the placenta that's attached to the uterine wall, okay? And this side of the placenta is covered with blood vessels. That's how, when it attaches to the uterine wall, right? The uterus has open blood vessels. This has open blood vessels, okay? And that's how the nutrients and the toxins go back and forth through the umbilical cord. Once you deliver, you have to deliver the placenta afterwards. So the placenta detaches and you deliver it through the vagina. When you look at that, you're going to see all those open blood vessels. And it's at this moment that we start bleeding the most, okay? This is the heaviest point of bleeding. And this is where a postpartum hemorrhage is likely to occur if we're going to have it. And for those of you who don't know what a postpartum hemorrhage is, we have a video on that. We'll link that into the description for you. So you're now bleeding, and the way your body naturally stops this bleeding is to contract the uterus back down. That's why you feel that cramping afterwards. That's the uterus contracting back down. Now, it used to be that this just happened on its own. But after each subsequent baby, the more babies you have, the more stretched out your uterine muscles are, and it makes it harder and harder and harder for it to contract back down, which is why the more babies you have, the higher risk you have for a postpartum hemorrhage. Well, now in today's modern day and age, we've learned how to make medicines that help with a lot of these processes. Back in the day, we just had to let our body do what it was going to do. But nowadays, we can utilize medications like Pitocin, which again causes contraction, so it speeds up that contracting process of the uterus to help prevent a hemorrhage. Okay, so that's all fine and good. Now, to your question, can you refuse Pitocin? Absolutely. You can refuse anything that you want. Now, why would you refuse Pitocin? That's a big question a lot of people ask. So Pitocin, potentially could cause a little bit of pain because, because you're causing contractions. You could be allergic to it, stuff like that. You just could be not wanting a lot of medication. Those are all valid reasons. But there is another set of reasons why Pitocin can become an issue, and that's related to breastfeeding. So the milk ejection hormone, the one that says send out milk, squirt out milk, that is also oxytocin, which is the natural form of Pitocin. Okay. So our body makes oxytocin. When you have an orgasm, oxytocin is released. This is the love hormone, okay? It's released to help your body contract. So you make your own oxytocin after delivery, which is going to help your body contract the uterus back down. This is also the milk ejection hormone. Now, when you're trying to breastfeed, if you go ahead and get a bag of Pitocin after your birth, what happens is you fill all of your natural receptors with Pitocin, right? So now your body has all these empty spaces that have been full, and it says, oh, wait, I don't need to make Pitocin right now. And so as a result, it stops Pitocin production, or oxytocin production, I should say, for about 18 to 24, maybe 26 hours after birth, because you filled all the receptors. And see, those receptors stay full for a while, and then they have to empty until enough of them are empty for your body to go, oh, wait, I'm supposed to be making milk. I'm supposed to be making oxytocin right now. That happens around 24 to 36 hours. Your body starts to ramp up production, which is why around day 2, you start to see milk coming in more and more milk in a pump, because now your body's sending the signal to send out the milk ejection reflex, okay? So again, if you're getting that Pitocin right after birth, you fill all those receptors, your body doesn't do that. It can inhibit your milk supply. Oxytocin is also coming in these big bags of fluid. And when you have big bags of fluid, you get swollen. And some of that swelling goes to your breast. And if your breast is swollen, that means the milk ducts that are in there are smaller because they're compressed. And until some of that swelling gets out of your body, then you don't have enough space to make lots of milk, okay? So those are a couple reasons why you might want to refuse Pitocin. Now, $1 million question. Do I recommend that you refuse Pitocin? I do not, okay? A lot of lactation consultants are very, very anti-Pitocin after birth. I am a lactation consultant. I've been a lactation consultant for 11 years now, so I'm very familiar with the milk ejection reflex and how to make milk, and I've worked with women who haven't been able to make milk. I've seen the swelling in the breast. I've seen that all. And I don't feel that I don't feel that stopping the use of Pitocin after birth is going to assist your milk that much. However, I have also seen hemorrhages, and a hemorrhage that, if left untreated, could lead to you needing a complete hysterectomy, which means you are not having any more babies, and it could also lead to a maternal death. And that is far worse than not being able to make a little bit of breast milk. And so for me, I think the benefits of Pitocin after birth far outweigh the risks to your milk production. But ultimately, you get to choose your own health care. Just make sure you understand the risks versus benefits before you say no to Pitocin. And please, 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 if you say no, please make sure you're open to it if you hear them saying that you're starting to bleed. Hi, Kyle. Welcome. So a midwife can induce multiple ways. How would a midwife induce? A midwife can induce using several medications, including Cervidil, Cytotec, and Pitocin. Usually what happens is the midwife will wait until you're about 39 to 40 weeks, and then they will let you know what kind of medication that they're going to use, okay? And so what you want to do is there's a lot more detailed information, because there's a lot of reasons that would go into deciding how to induce. So if you want, you can check out our video on induction methods, and we will link that into the description for you. Let me go ahead and answer our next question about C-sections. So when is it usually okay to shower and bathe after a C-section? And is it okay to use Epsom salts? Okay. So when is it okay to shower and bathe after having a C-section? Like right away, like 18 hours, like as soon as you get out of bed. The only reason why you shouldn't be taking a shower, like literally right after you get out of bed, is because you are potentially a little dizzy the first time you get up, and that hot water might make you more dizzy. So that would be like it. But basically, the second the bandage comes off, please start showering. One of the biggest risks for getting a infection of your C-section incision is not cleaning. So let's just be honest. All of us, after we have a baby, most women will go home looking like they're 6 months pregnant, which means you have that little belly overhang. And of course, if you're heavier, you may have an even larger overhang. And that little overhang creates a pouch, right? So this is your stomach and you got this little overhang. And up here is the C-section scar, right? So what happens is your belly kind of hangs down over it and it creates a dark, moist area for bacteria to grow, okay? And what happens is what you have to do is you have to lift this fold up to clean. And it's very important that you clean. And a lot of times what happens is women aren't cleaning that area. They're so afraid that they leave it alone and it ends up getting infected. Now, what should you do for cleaning? No perfumes, no lotions, no powders. In this case, I would not use Epsom salts, and you should not be taking a bath. All you need to do is just warm soapy water and then warm water to rinse, and then you pat dry. That's it. Very simple. The only other thing I would tell you for taking care of your C-section incision is you want to try once or twice a day to lay on your back, okay? And if you have that overhang, you want to lift your belly up to expose the incision and try to keep it like open to air for like 5, 10, 15 minutes if you can, because being open to air helps air that out. Do not apply Neosporin or alcohol or anything like that unless you've been directed by your healthcare provider. All of that can actually cause irritation, which can actually lead to infection. And again, let me be very, very, very clear. No powder. Powder is actually known to cause infection. So powder has sugar in it, believe it or not. And that sugar feeds the bacteria that's down there, making them grow and making it worse. Okay. So that's how I would do that. As far as Epsom salts, for any of you guys who are having a vaginal birth, soaking your bottom in Epsom salts after you come home, especially if you have any kind of tears or lacerations, can be really soothing and really nice. What happens if the baby gets stuck for birth? If a baby gets stuck, you would need a C-section, okay? That's pretty much the only way it would happen, is that if you can't get the baby out vaginally, we just have to do a cesarean section birth for that. Okay, so going along birth, right? Hi, when should the baby get a bath after delivery? So this was another good question. So we have a whole video on delayed bathing. And for those of you who haven't seen it, I would encourage you to watch it. I'm going to have it linked into the description. But when you should bathe your baby is very sometimes controversial and subjective. I've heard a lot of different things. I've heard people who want the baby bathed right away. I've heard people who wait like a week. Generally speaking, now we are using a delayed bath at about 24 hours of age. The reason why we do this is because this gives the baby a chance to spend a lot of time breastfeeding and getting used to that before they get stressed out by a bath. A bath is extremely stressful for a newborn because it makes them cold. And once they get cold, they need to be warmed up, and the whole experience can be very disruptive. And then they kind of shut down into like a restorative sleep. So we want them to be more alert and awake the first day to help encourage them to breastfeed so that they breastfeed often. We also want some of that vernix, which is that like cheesy kind of substance that's on their skin, to absorb in, because it's really good for their skin and really protective. So as a result, we wait about 24 hours. There are some exceptions to that. You know, if your baby is meconium stained, which means they pooped inside your belly, we are going to go ahead and we are going to bathe them sooner. If you have an infection, if the baby looks like they're not doing well, we're going to bathe the baby, okay? We're going to go ahead and take care of that. For those of you who want to wait longer, you know, in my opinion, waiting possibly up to 48 hours, especially if we're trying to encourage breastfeeding, might be okay. But after 48 hours, your baby needs a bath. You know, understand the vagina Yes, it is natural bacteria. Natural vaginal bacteria exists. There's natural bacteria on our skin, like just our regular skin. But that bacteria needs to be washed off your baby at some point. Now, I'm not some huge germaphobe, but understand your baby is immunocompromised. I think a lot of people forget this. Our babies don't need to live in a bubble, but they have no immune system, okay? None at all, okay? And so as they're exposed to different things, they are absolutely going to develop that immunity. But in the short run, they don't want to be exposed too much. And so after a while, you want to let that bacteria be, come off. Kyle, yes, for having a baby does hurt. And so it's very important for a lot of you to understand your pain management options. There are natural stuff that you can do. There's also epidurals and spinal anesthesia. And then there's some oral and IV medications that you can use as well. Childbirth for most women does hurt. One of the things that you can do is hypnobirthing. Hypnobirthing can be extremely effective for managing pain during birth. And I think we have a video on hypnobirthing. I think so. I'm going to look and see. And if we do, we're going to link that into the description. All right. So I had a question about hemorrhoids. And it said, please help my wife. She has external hemorrhoids after pregnancy. And what can we do? Creams, medicines, tablets, anything. Okay. So hemorrhoids are enlarged blood vessels. Okay. They're enlarged blood vessels that kind of bubble up and they fill with blood. And it's extremely common to have them in the anal region during pregnancy and after birth. So why does this happen? This happens because, when you're pregnant, first of all, it is extremely common for women to get constipated. And when you're constipated, you have to strain to go to the bathroom. And so that straining kind of pushes pressure onto those blood vessels and they pop. They pop. Sometimes they pop open and you bleed. And sometimes they kind of pop and the blood vessel just expands. And now you got this balloon of a blood vessel, thus a hemorrhoid. You can get them internally inside the rectum and also externally. That means you can see them outside of the rectum. Now, your anus is extremely sensitive. It's extremely sensitive. And so you can get a lot of pain in that area. So when you have pain, it can be really bad in the anal region, which is why everybody's so worried about hemorrhoids. Now, there are creams and tablets and different things that you can use for this. When you are pregnant, you absolutely cannot use any of these without talking to your healthcare provider. Once you've had the baby, though, you should be pretty much able to use whatever you want. Of course, you need to ask your healthcare provider to make sure there's nothing going on with you specifically that, might prohibit something. You do want to have them checked out also, because if one of your hemorrhoids has gotten infected, that would actually make the pain worse. I personally like witch hazel pads, Tux pads, because they're these little cotton squares. They have the witch hazel infused into them, which is a substance that can help shrink the tissue and make it less painful. So that's like really good. And then you can lay it on top and leave it there in between going to the bathroom. So it can help just like absorb in. So I really, really, really like Tux pads. But ultimately, you need to get evaluated. If the hemorrhoids are too bad, you may want to see a proctologist, which is a doctor who specializes in that anal region, and they may need to do a surgery to remove the hemorrhoid. It's called a hemorrhoidectomy. So that was a good question. Hi there. For those of you who are joining us, my name's Dr. Samantha. I'm the maternity mentor. Welcome back to one of our live Q&A sessions that we have here every Monday at 9 p.m. Eastern Standard Time. Please feel free to put any of your questions into the chat. I love interacting with you guys and I love answering the questions live. Kyle, that's actually a great question. I really actually like that question a lot. So can you still have a breech baby natural? So natural, I'm going to assume means vaginal. So what is a breech baby? So a breech baby, here's your uterus. Your baby's supposed to be head down and its butt down. Okay. That's a breech baby. So breech babies can be born vaginally. However, it is not recommended at all, okay? Most successful breech births nowadays happen by accident. Either the baby is premature or the baby is small and the delivery kind of just happens out of everybody's control. So why do we not want to have a breech baby? So the biggest reason why is that the head can get trapped, okay? The head is the largest part of the body, believe it or not, when you're delivering. The shoulders have a little bit of maneuverability and they can kind of slide in, but the head has to just come out, okay? And when a baby is born breech, the head can get trapped. What can happen is as the baby comes out, the uterus can contract down onto the neck, okay, trapping the head. Once this happens, we're in a medical emergency. So when you start to deliver a baby head down and you're having a medical emergency, like the heart stops in the baby, or you have a shoulder dystocia. Shoulder dystocia is where the shoulder gets caught. So the head is down, the shoulder gets caught. We have a whole bunch of maneuvers that we'll do to try to get the baby out. But if we can't get the baby out, we push baby back up. We try to get baby back up into the uterus or as far in there as we can as we rush you to an emergency C-section. That way we can try to deliver the baby. If your baby is born butt first and the uterus contracts down, we can't do a C-section. So we have to try to do whatever we can manipulation-wise on your cervix to get the baby out as quickly as possible. There is no way to do a C-section once you have a baby that's body out and head in. So it is extremely challenging. There's a lot of risks that can happen. Babies that are born breech first, that means their legs are up by their ears. That can cause hip issues and different things. So can it be done? Yes. Is it recommended to be done? No. Do I recommend it to be done? No. You should have a C-section. Flat out, any of you who have that, I would not recommend anything but a C-section done in a hospital. All right. So we had a question about premature birth. Hello, I lost my baby at 15 weeks of pregnancy. I had a rupture of amniotic fluid. When I went to the doctor, they told me that my membranes had prolapsed and nothing could be done. I gave birth to 3 children naturally. I had no injuries or abortions. What could lead to ICI? Is it possible that the cause of the miscarriage was not ICI? So I looked at this question very carefully. So if you're on, I want to let you know that I'm not exactly sure what you're referring to for ICI. Okay. The only thing I could think of is you're talking about intracervical insemination. This is where if you're not able to get pregnant naturally, you go ahead and they will have like the semen put into a syringe and they kind of insert it in, right? So that is the only thing I could think of for ICI. But a premature rupture of membranes can happen for a variety of reasons, okay? And what I would tell you is that just because you've had multiple safe, healthy pregnancies doesn't mean that an artificial rupture of membranes is preventable. It just sometimes happens and we don't really have a reason why. However, going back to the antibiotic question, one of the things I'll tell you is one of the most common causes is infection. Okay, so a UTI, urinary tract infection, that is left untreated can absolutely lead to a premature rupture of membranes. And so it's very important that you make sure that if you have anything going on, any discharge, any smell, you feel funny, your heart rate is risen, your heart rate is high, you're getting a fever, your belly hurts, you want to get checked out. A lot of moms hesitate to get checked out. They're so worried, they're worried about interrupting somebody at 3 a.m. They don't want to seem silly. I'm telling you, just do it. This is what your doctors are being paid for. This is what your midwives are being paid for. They're there to help you out. And that's what the hospital's there for. So I would tell you that for premature rupture of membranes, it's very important that you're getting taken care of. Okay. For any of you guys who are joining us, please feel free to put your questions into the chat. We had a couple questions on my STD videos, sexually transmitted diseases videos. And this was, these questions I think are very important because this is such a taboo subject. And I don't think it should be, okay? Because there's some sexually transmitted diseases that, if left untreated can cause serious issues for both mom and baby. So one of the questions was, what about oral warts? Can it be passed down to the baby through the placenta since it's located in the mouth and throat? What if the wart accidentally gets swallowed? So this is an interesting question, and I'm not 100% sure what this person is referring to. So what I'm going to say is, without a little bit of further information, I cannot give you a 100% answer, but I'm going to go ahead and tell you that when you're talking about warts, generally speaking, this is not something that we're going to have to worry about unless an active infection is being dealt with. Definitely swallowing a wart is not going to make a difference, because that wart that's being swallowed is going to be burned to, like, it's going to be broken down by stomach acid. Okay. What I would tell you is, if somebody had oral warts or throat warts, you wouldn't want them to be kissing the baby, because again, the baby is immunocompromised. Also on those videos, I'm pregnant with syphilis. I got treated, but the symptoms are still there. What should I do? Okay, this is a very important one. So unfortunately, due to antibiotic resistance, we have a lot of infections, not just sexually transmitted diseases, but other infections that are now antibiotic resistant. So remember how I was talking earlier about the augmentin, and I was telling you guys that you have to take all of your antibiotics. You can't just stop when you're feeling better, because that 20% is sitting, waiting, and building a defense wall. That example is antibiotic resistance. That's exactly what antibiotic resistance means. And what's happening now is people are not completing their antibiotic regimen. And these bacteria, they want to live. They are figuring out how to get around the system. And then when we're sending back these standard medications, it's not working. So in your case, if you had the syphilis and you got treated, but you still have the symptoms, you need to go back and you need to get tested. My guess is you still have an active syphilis infection. It was probably antibiotic resistant, and that is now the case all over the world. Antibiotic syphilis and antibiotic resistant syphilis, gonorrhea, and chlamydia are all over the world now. You would need to go ahead and get retreated with a stronger antibiotic. Now, if you leave these infections untreated, it can lead to a lot of issues with the baby. For example, chlamydia, if left untreated and the baby doesn't get treatment for the eyes, the baby can actually be blind. Okay, so it's very important. We had a question on my VBAC video. What about CPD? Okay. And I thought this was a great question. I did actually leave CPD out of that video because it's extremely controversial. So let me give you guys some initials broken down. VBAC, vaginal birth after cesarean section. This is a mother who's attempting a vaginal birth, a natural birth, whatever you want to call it, after she's had a surgical delivery. VBACs are slightly controversial because a lot of doctors are afraid to do it because of the major complication, which is uterine rupture. That's where the uterus actually rips open. Okay. And it can usually happen at the site of the old C-section incision. CPD, cephalopelvic, oh my gosh, disproportion, I believe it is. Oh my God, I just forgot what that D was on the spot. Okay. So this is basically a fancy term for saying the baby is too big to get through the pelvis. Sorry, disproportion. That's what it is. Okay. All it means, baby's too big, pelvis is too small. Big head, small vagina, vaginal canal. Okay. This is an extremely controversial subject because it is one of the most commonly used reasons for an elective C-section. So we don't want to C-section you unless we have to, or at least that's how it should be, because there are way more risks for you and baby with a surgical delivery than they are with a vaginal delivery. However, for a variety of reasons, doctors may try to encourage that. And one of the reasons why they do that is for cephalopelvic dysportion. Now, this is a real thing. The most common place I think you would see it is with diabetes. So babies who have a mom who is diabetic, these babies tend to be large. Even if the mom has her blood sugar under control, usually by the time we're figuring it out, the baby's just getting bigger and bigger due to all the sugar it's being exposed to because the mom's insulin isn't working properly, right? So these babies get to be large for gestational age. And once they're too large, they can have trouble passing through the vaginal canal. They're too big. And so if we try to deliver a baby that's too big, we run the risk of stuff like shoulder dystocia, and shoulder dystocias can end up being medical emergencies. So we want to make sure that we try to avoid that. And that's why we're keeping an eye on how big the baby's getting and whether we think a vaginal birth is realistic and feasible and safe. That would be a true example of a potential CPD, okay? But a lot of times these doctors will just say it to say it, and that's where it's controversial. And I can't really even give you any guidance to prove that the baby's too big or doesn't exist, like the CPD doesn't happen in your case. So what I would tell you is ultimately with CPD, you need to hopefully have a good working relationship with your provider that you trust, that when they tell you there's a CPD there's a disproportion between the baby size and your pelvis, that they're telling you the truth and that they need to do a C-section. Now, leading into that question, we actually have this other question, and it kind of goes along with that. So I had a question come into my labor and delivery video that said, can doctors like OBGYNs and primary care lie, and you can get to go to another doctor if you're going through changes, right? And you don't like the person. So this kind of goes hand in hand, and this is why. One of my original videos, like back in the day, and we'll link it, is like how to interview your OBGYN and how to interview your midwife. And the point of interviewing these providers is to figure out, do you get along with them? Do you trust them? Are you on the same page? Asking all these questions to figure out if you think they're going to meet your expectations. One of the things you should ask for a OBGYN is, what is your C-section rate? Okay. So one of the things that I have found in practice is that OBGYNs who have these astronomical C-section rates, like 60, 70% C-section rates, most of the time, they're the guys or girls that say there's a cephalopelvic disproportion. So they're the ones who use that. Okay. So I would like to tell you that that's the very important reason why you want to interview your providers and make sure you're on the same page. You can ask them stuff like, what's your C-section rate? What's your induction rate? What's your episiotomy rate? You can ask all of those questions, all of them. It's completely in your right to ask those questions. Here's the other thing. They may not answer you, but I cannot answer you a question for you, and you still may feel like we're going to have a good working relationship. Just because you don't get information doesn't mean that you won't trust that person. It's all about how they respond to you. Are they open to even having the question? Maybe they can't answer you because they don't know their C-section rate, but they're fine with trying to figure it out for you. You know what I mean? So what I would tell you with like the CPD thing and going back to this other person, you can absolutely ask for new providers if you don't trust the opinions that you're getting. However, I do want to say to you, if your provider is recommending a course of action, don't just ignore it if you don't agree with it. And that's, I think, part of the birth plan video that I talk about, like, don't being just completely rigidly opposed to stuff. I have seen some very unfortunate outcomes in the hospital when people have been upset with what was recommended. They've tried to find a new provider to get around that, and things have gone bad because they didn't follow the original advice. Okay. So understand, if you pick somebody and you trust them, you know, they may have to deliver bad news to you. They may have to say to you, you need a C-section, but you picked that provider for a reason because you trusted them. And it's okay for you to ask the risks, the benefits of this, that, but understand you trusted them for a reason. So, you know, really listen to what they're saying to you medically. Hi, Ali. I'm hoping I said that right. So we just recently discovered that my wife has a complete placenta previa. Would you please give us any insight on what to expect? Is there anything we can do on our end? This is our first pregnancy and we are nervous. Oh, that is really, really hard, but it's not, it's okay that I can tell you about that. So let's talk placentas. And I think I have a video on that. We'll try to link that if I'm right. If not, I was planning on doing one. Uterus. Okay, so we have our uterus, placenta. This is the organ that feeds the baby. So most of the time, for most of you who are on, placenta attaches to the side. Okay, this is just a normal presentation for a placenta. For some people, like Ali and his wife, the placenta has decided to go somewhere else that it shouldn't. So we have the uterus, and at the bottom is your cervix. Okay, and the placenta for them is over top of that cervix. So that's a complete placenta previa. A partial is where it's kind of on the edge. You see how it's kind of over? So this is the cervical opening right here. So it's kind of on the edge of it, like it's like partial. And then a marginal is right next to it. Okay, so those are the three types of placenta previas. Okay, and what happens is that placenta, once it's here, we got an issue. Sometimes the placenta will migrate and move up as the pregnancy gets bigger. But a lot of times, once you have a complete placenta previa, it's kind of like that's where it's going to be, especially if the pregnancy is about 20 to 24 weeks or later. If you're still really, really early on, it's possible that it will migrate. But once you hit about 20, 24 weeks for a placenta previa that's complete, then usually it stays where it is. So what do? When you're getting ready to have a baby, what happens is your uterus starts contracting and you have this cervix here, right? And this cervix is supposed to be long, thick, and closed. This is the closed part. And for anybody who's heard about the mucus plug, the mucus plug is a line of mucus that stays inside this to keep it shut, okay? So when the cervix dilates, that mucus plug drops out, okay? So we have our cervix. Now, what's going to happen is when you have the contractions, I'm going to move my cervix like this. The contractions help that cervix thin out and move away. Thus, you dilate to 10 centimeters. Now, when you have a complete placenta previa, remember, these are blood vessels that are feeding the baby. So if this opens at all, you have open blood vessels, you're going to start bleeding. The second you dilate, what happens is the baby and the mom have a chance to hemorrhage. And that's why Ali and his wife are nervous, because that's a very scary thing. The nice thing, Ali, is that we now know a lot about this. And usually what I'm about to tell you is what happens. So Braxton Hicks contractions are the contractions that help your body practice what labor is going to look like. They also start to prime the cervix. They start to kind of let it soften, let it understand that it's going to eventually be opening, right? So around 24 weeks, we start to have Braxton Hicks. And Braxton Hicks slowly over time can start to move at the cervix and give it some, like, help it dilate, help it thin, stuff like that. So by the time you get to the end of your pregnancy, you're ready to go. Since we know this, we usually will bring moms in who have a complete placenta previa around 30 to 32 weeks into the hospital. And usually at that point in time, this mom is with us for the rest of her pregnancy. The reason why we bring her in is so that if anything happens, any blood is seen at all, she's done. She's C-section. Okay? Because a complete placenta previa is an automatic C-section. We cannot let we cannot let the cervix dilate at all. She'll start hemorrhaging and the baby will start hemorrhaging. So it's a C-section. So you're in the hospital so we can monitor, so we can prevent a hemorrhage, so we can have a controlled delivery that's good for both mom and baby. If you are having no complications, we usually will go ahead and schedule a C-section for around 34 weeks. Now, the reason for that is we can't take the chance that the cervix dilates at all. It's extremely dangerous for mom and baby, like big time dangerous. So instead, what we choose to do is bring you in. We get everybody ready. We let the neonatal intensive care unit know that we're going to have a baby coming that's a little early. We give mom all the steroids. We give mom all the magnesium to help the baby's brain and the baby's lungs to be safe. Mom is well nourished. She's well hydrated. She's gotten all of the care that she needs. So both mom and baby are in a very healthy place to have a very safe delivery. And on top of that, because she's in the hospital, we make sure we have all the staff in place. This isn't an emergency. It's a scheduled C-section, okay? So if an emergency does happen, she's there and we're ready. But if it's not, we have this nice scheduled, controlled cesarean section delivery that has wonderful outcomes. Now, your baby will probably have to stay in the hospital for a couple weeks just because we're delivering the baby prematurely. But that's okay. The baby will be good and we'll go home with you. Now, this stuff is changing all the time. And depending on where you are, your area might be allowing mom to stay pregnant longer. Okay. Ultimately, we want to keep the babies in as long as possible. So they are trying to figure out when's the good time to deliver a baby via cesarean section when it's complete placenta previa. But we really don't have an awesome answer yet because, of course, women go into premature labor all the time. But that's the approximate idea of it. And now, Ali, what I would tell you and your wife to do is I actually have a whole bunch of videos on cesarean section. I have a video on what to expect going in. I have a video on what you can see in the operating room. I have a video on C-section incisions. I have a video on the first 3 hours after a C-section. Please check out all those videos. I think those videos can help you and your wife out a lot. So you also understand what things are going to look like along the way. And that's part of the reason why I did some of those was to help people because it is nervous. People are always nervous to have a C-section. It's hard. For those of you who are joining us, I am answering questions from people in the chat as well as questions that I have gotten on my videos. So I got a question on tandem breastfeeding, and it said, what about the colostrum? Shouldn't the newborn get all of the colostrum? Will my older child drink the colostrum? So tandem breastfeeding, for those of you who don't know, tandem breastfeeding is when a mom is breastfeeding a baby and a toddler, okay? So the baby should be the priority, okay? So when you deliver, you usually have colostrum again, and the newborn is absolutely the priority. And so unfortunately, you are going to have to teach that toddler that they have to wait their turn. Okay. We hear all the time about babies who can't successfully breastfeed because the mom doesn't have milk. So we all know that the colostrum is very small, and that toddler is going to be really, really good at just draining the breast. And so therefore the baby might not get anything. However, that toddler is really, really good at draining the breast, which means that once you've offered the newborn both sides, you can let the toddler feed right afterwards. And that's stimulating the breast, which may actually help your milk come in faster again. But yes, you want to make sure that the baby is getting first dibs. So the baby always gets fed first, then the toddler. Now, if your toddler drinks colostrum, it's totally fine. They're totally safe. There's nothing wrong with it. It's not going to hurt the toddler. But yes, make sure you prioritize that newborn. We had a question on the breastfeeding video. How do you know whether the baby needs more or less stimulation during breastfeeding during the day? My nearly 5-week-old is feeding for hours at night, but also in the day. For instance, 2:30 to 8 p.m. today, feeding off and on with some time in between to play and look around, but did not nap. I'm feeding on demand, so whenever he's hungry, which seems all the time. Okay, so this is a complicated question. How do you know whether the baby needs more or less stimulation during breastfeeding? You know, if the baby's like basically snacking on you all day long and like falls asleep after 5 minutes, the baby needs more stimulation. What I will tell you is that sounds like too much breastfeeding. That sounds like a baby who's not getting enough. So either one, your baby is not getting enough, your supply is not enough, and you need to see a lactation consultant to fix that. Or two, your baby's using you as a pacifier. So I'm going to link our pacifier video. Pacifiers are recommended by the American Academy of Pediatrics once breastfeeding has been established, which is 2 to 3 weeks after delivery. So for a mom with a 5-week-old, if your milk supply has come in and is very robust, you should have no issues with you should have no need to be feeding the baby that often. And therefore, I would recommend that you start using a pacifier because pacifiers are recommended. If your baby is really not gaining weight well, is not really peeing and pooping well, unless you do all this feeding, then you need to see somebody because your breast milk supply is probably a little too low. And we want to make sure we understand what's going on because there may be an easy fix to the supply issue. It could also be that your baby is tongue-tied. And if your baby is tongue-tied, you might need to get the baby to have a revision in order to loosen the tongue and help them transfer milk better, which is why you want to see a lactation consultant. We always have several questions about bleeding. So I like to read them all and then kind of give you all an answer, together, because it's usually all pretty much the same. And this is very scary for a lot of women. Hi, I'm 18 weeks pregnant and my pregnancy has been going great. And then all of a sudden I got up around 12 p.m. to use the bathroom. And when I wiped, there's blood. So I think I'm spotting for the first time. Then later on, there was more blood and heavier. Literally, I have a pad on right now. The blood clots are stringy and my lower stomach hurts. Not as much, though. Just feels like I'm on my period. Another one. I'm 13 to 14 weeks pregnant. Bleeding suddenly the last few days. I was admitted to the hospital. Baby is okay. Activity is okay, but not clear on the bleeding. I'm 6 months and I've been experiencing spotting. Is that normal? My cousin is 1 week pregnant. She had sex and started bleeding with some clots without cramps. It's now been 3 days and she's bleeding. She's so worried. Hi, ma'am. I'm 14 weeks pregnant. I started bleeding from 6 weeks every second day. It's starting brownish and now bright red. I'm afraid. Please let me know what I should do. And finally, I'm having spotting that's pinkish for 6 days now with no pain. I'm 9 weeks pregnant. Should I be worried? So I like to actually put all these together because it hopefully will tell you guys that you are not alone, okay? That the bleeding is something that happens to a lot of pregnant women for a variety of reasons, and it's very scary. But there's sometimes the bleeding is not scary. It's happening for a normal reason, and it's not a big deal. So we have a couple bleeding videos. I'm going to link them into the description. What you need to know is, first of all, it's very important for you to be able to describe the bleeding. That's why we have a bleeding color, like the color of your blood. When it's pink, it usually means it's mixed with some kind of fluid. That's usually the spotting color, pink. Red and bright red and dark red, those are kind of worrying colors, especially bright red. That usually means you have active bleeding going on. And then brown is old blood. Okay, this is blood from a resolving bleed. Okay. Anytime you see any of these, you need to call your doctor and get checked out because there's a variety of reasons why they could happen. For example, Ollie's question about a placenta previa. If you've never had an ultrasound, you might have a placenta previa and you may have your cervix is starting to dilate prematurely. Thus, you have spotting. You want to get that checked out. The way we would check that out is with an ultrasound. You could also have something called a subchorionic hemorrhage, and we have a video on that. We will link that into the description. But a subchorionic hemorrhage is basically a pool of blood underneath the placenta, which just kind of exists there. It just happens. They usually get smaller and smaller and resolve, but sometimes they'll cause a little bit of a bleed. Most of the time, a subchorionic hemorrhage is completely fine and safe, and your pregnancy will be fine. You can have spotting, especially early on after sex. That was one of the questions that was kind of asked. That happens because the hormones that are good for a healthy pregnancy, those hormones actually thin out the vaginal tissue, making it easier to tear. Sometimes the bleeding is actually coming from a hemorrhoid. We talked about hemorrhoids earlier. So sometimes one of those hemorrhoids will pop and you don't realize that the blood is actually coming from there instead of the vagina. So ultimately, it's very important for you to get this checked out. Now, in a couple of those questions, we heard about women who are having pain. If you are having bleeding and pain, go to the hospital. Period. End of conversation. There are a lot of things that can happen that we can prevent if we see you early enough, okay? Because if you're dehydrated, that can cause contractions. Contractions can lead to dilation of the cervix, and that can lead to bleeding. So if we get you early enough, we can give you IV fluids to get rid of that dehydration and potentially prevent preterm birth, okay? So ultimately, for any of you guys that are there, I want you to make sure you're getting checked out by your healthcare provider. We had a question about we had a couple questions, I'm sorry, about labor and delivery. So, these questions, my legs hurt when I lay down and when I get up. Do you think this is a sign of going into labor? I'm supposed to be induced tomorrow due to a pulmonary embolism, but my mucus plug came out yesterday and I'm having contractions that are 5 minutes apart. My whole leg feels tight and I'm having trouble breathing. So she's worried. And then I'm having spinal pain and repeated pains during my pregnancy, and my umbilical cord is becoming hard like a stone. Okay. So one of the salient points in all of these is pain. Okay. So listen, guys, you shouldn't be having pain during pregnancy. That's really not a thing, especially in the belly. So sometimes we have carpal tunnel pain. Yes, we might have some back pain that you need to see a chiropractor, get a massage. Make sure you're seeing a massage therapist who's certified prenatal massage therapist. But ultimately, okay, if you're having stomach pain that comes and goes, lower back pain that comes and goes, you need to go to the hospital and get checked out. That sounds like labor. Okay. It's very important. Moms just feel so worried about, bringing something up, and, it's really okay for you to go and get checked out. For any of you who are still with us, thanks so much. I am going to answer this final comment. But if you guys have any questions, please put them into the chat. And then I'm going to give you a preview of next week's video. Or tomorrow's video, I should say. So we had a comment on my postpartum depression in fathers. Dealing with this myself right now. Just feeling like my life is over and all I will have moving forward is sacrifice and boredom. All my goals can never be achieved now. Okay. So I really thought this was so really brave of this dad to share, and really so telling of what it can feel like as a father who has postpartum depression. Okay. So postpartum depression is a real thing in dads. A lot of people want to say that it's not real, but it's actually extremely, extremely common. Up to 50% of fathers will experience postpartum depression, especially if their partner is experiencing postpartum depression. And of the 10% of dads will experience that on their own. Once you have a baby, babies are the most wonderful thing. Children are fantastic. It also really stinks. Okay. I'm just going to say it. You're both tired. You're lucky to get sleep. You're lucky to be able to eat. Your house is a wreck. Nobody's doing what they wanted to do. You try to leave the house, she's upset. She tries to leave the house, you're upset. It's like a mess. Everything's a mess. Okay. It doesn't mean it won't be fantastic, but it's a mess and it's hard and you have to get used to it. And oftentimes, especially what happens for fathers is this. Everything becomes the mom. You got to take care of the mom. She just gave birth. She just did this. She just did that. Oh my God. How, she just had a C-section. She just had your baby. All we hear about is taking care of mom. Okay. I'm not saying moms don't need help. Okay. And understand, dads, moms need help. Okay. If she just had surgery, she's in pain, she needs a lot of help. Okay. She is scared and she's vulnerable and she wants to make sure you're by her side. Okay. She feels very scared right now, but you might be scared too. You might need to do stuff too. And this is where I think we make big mistakes. I actually have a video from a talk that I did in a local hospital a couple weeks ago. And this was one of the things that I mentioned. 95% of the time for the first couple weeks, dads, you need to be there for her. It sucks, but that's how it is. but you are allowed to ask for things. And moms, you should let dads ask for things. Okay. That saying, you can't give if you have an empty cup, like you need to fill your cup before you can pour into others or whatever it is. Like, listen, if you don't have anything else to give, you can't be good support for mom. Okay. You can't. And moms, you need to understand and recognize this. If dad needs to go take a drive, if dad needs to go play golf, if dad needs to go do any number of things, he needs to be allowed to do this, because when he comes back, he's recharged. Okay. He's recharged. He feels like he's himself. He feels like he is still allowed to want things. Okay. Because he is allowed to want things and he is allowed to do things. Dads, once you've filled your cup, please make sure you fill hers. Please make sure you're there. And yes, there's a lot more pressure on you. There is. But it's important for you to make sure you recharge yourself so you can give 110% to her. Now, what can you do, dads? Because this is the other thing. Like, again, there's all this, oh, look at him. He's so selfish. Look at what he's doing. Why? I can't believe he has a newborn. He's leaving her home. This is what you do. Number one, you make sure she has help. Ask friends, ask family to come help her. Number two, you bring home dinner. Okay. Come home with a pizza so she doesn't have to worry about it. Okay. Number three, ask if she needs something while you're out. Ask if she wants her favorite Starbucks coffee or she needs you to pick something up from the grocery store. I'm not asking you to be a slave in order to go out. But what I'm saying is these are also a couple little things that you can do that probably aren't going to be too hard. And so not only have you had a chance to go do something fun, but you've also given her a little break by knowing you don't have to cook dinner, or yeah, I can stop by and get the bread. That's not a problem. So these little tiny things that you're also doing on your way back go a long way to reinforce that you're there for her. Also, make sure you're offering her the same type of deal. Make sure that you say to her, hey, do you want to go out next Saturday and get your hair done and your nails? I'll watch the baby. Hey, do you want to go out and see your friends on Thursday night? Yep, I got the baby for you. Make sure you're both doing that. Okay, that's the other very important thing. But it's very important also for family members. Family members, do not dismiss dads and their feelings. Do not do that. Okay, we are sending the wrong signal to our dads when we dismiss what we commonly say as selfish feelings. And what happens is it destroys relationships and families. We need to acknowledge everybody's feelings, and we need to figure out a way for both partners to move forward and to move forward in a way that's healthy and allows them to adjust. No, it's not going to be the same. You're not going to get to do everything you usually wanted to do. And life changes. You have to work a little harder when you have a baby, but it can be fabulous as long as we're like supporting each other. So my name is Dr. Samantha. I am the maternity mentor. I am here every Monday at 9 p.m. Eastern Standard Time to answer your questions live, as well as any questions that you have given us on the videos. We are here to help you out. I love talking to you guys. I love interacting with you guys. So thank you so much, Ali. Thank you so much, Kyle and Jasmine, for asking your questions. I love it. Okay. We are also on Facebook, Instagram, and Twitter for additional content. Share the channel with your friends and family. Please like and subscribe to the channel. It really helps me out. And hit that notification button so you can be the first to get information or get notified of our latest videos. So for those of you who stuck around to the end, tomorrow's video that's coming out is fetal heart rate. So this has been a question that's been asked a lot. So in tomorrow's video, I'm going to explain to you everything you wanted to know about what we're doing when we're monitoring the baby's heart rate, what these changes actually mean when you hear some of these terms, why some things that may look like distressing to you are completely normal for us, what things are not normal for us, and why it's so important for you guys to let us monitor your baby's heart rate, and why the changes in the heart rate, when you hear, she had a C-section because the baby's heart rate went down. What does that actually mean? Okay, because most of you guys don't really understand what we see when we see it. And so I try to explain to the best of my ability, because it is a more complex subject, but why we're looking for what we're looking for. Okay. So I hope you take a look at tomorrow's video. I appreciate all of you. Thank you so much for joining me. I'm Dr. Samantha, the maternity mentor. Bye for now.